Hello everyone. We systematically studied knee anatomy at a special physical examination last class. Today, we will begin to learn about specific orthopedic disease of knee. First, let's learn about penile fracture. Penile can protect the knee joint and strengthen quadriceps. Penile fracture is more common in adults and the elderly, but extremely rare in children. So, how does penile fracture occur? We divided the causes of penile fracture into two categories: direct violence and indirect violence, among which indirect violence is more common. Different forms of violence will produce different fracture characteristics. First of all, for those patients caused by direct violence, the penile is usually comminuted fracture, and the quadriceps, adesma, and articular capsule are generally intact, with little influence on knee extension. For those caused by indirect violence, because the patient falls when knee joint is in the semi-flexation position. In order to avoid falling down, the quadriceps femoris contract strongly, and the penile is pulled strongly by muscles, resulting in fracture, and the fracture lines are mostly transverse. The quadriceps, adesma, and articular capsule will be broken. The two bone blocks will be displaced separately. The knee extension device will be destructured, and the knee extension function may be affected if the treatment is not timely or incorrect. Then we look at the clinical manifestation of penile fracture. When a fracture occurs, local pain and swelling will occur rapidly, and the knee joint cannot be straightened spontaneously, which is often accompanied by subdermal ecchymosis and skin abrasion of knee. However, when there is separation and displacement, you can feel the groove-like fracture in. And at the same time, there may be bonding crepitus or abnormal activities. The anterior, posterior, and lateral X-rays of knee joint can help us define the type and displacement of the fracture. Next, we continue to look at the treatment of penile fracture. In the treatment of penile fracture, we should clearly grasp the treatment principles. That is, preserve the penile as much as possible, restore the function of knee extension device, keep the articular surface intact and smooth, prevent the occurrence of traumatic arthritis, and repair the transverse fracture of the expanded part of quadriceps. At the same time, knee flexation exercise should also be carried out early to facilitate articular surface modeling. Different types of penile fractures generally adopt different treatment schemes. First of all, for penile fractures without displacement, or cracked fracture and star-shaped fractures with little displacement, the knee joint can be simply fixed in the straight position with peripenile pyxis apparatus. However, if the transverse fracture is displaced with 1 cm, manipulative reduction can be adopted, and the knee joint can be fixed in the straight position with the peripenile pyxis apparatus. If the displacement is large and manipulative reduction is difficult, the penile holder can be used for fixation. When there is soft tissue embedded at the fracture end, it is necessary to open reduction and internal fixation. During the fixation period, the patient should gradually strengthening the relaxation and contraction activities of quadriceps. And after the fixation is relieved, he should gradually do the fixation and extension exercise of knee joint. However, before the fracture has reached clinical healing, pay attention not to flex extensively to avoid reopening the fracture. Traditional Chinese medicine treatment of pinna fracture is similar to that of injury, and it is still a three-stage dialectical classified treatment. You can review the previous contents. Well, then we will learn about the common dislocation disease of knee dislocation. Knee dislocation is a knee joint injury caused by excessively rotation, flexure, and extension of the joint, which is mainly due to strong violence on the upper end of the tibia. Among them, specific etiology and direct or indirect violence, with direct violence as the most common cause. Based on the position of the upper tibia after dislocation, it can be divided into anterior, posterior, medial, lateral, and rotational dislocation, of which the anterior dislocation is most common. And the medial, lateral, and rotational dislocation are rare. At the same time, it can be divided into complete dislocation and partial dislocation based on the complete or partial separating of the femoral condyle and tibia condyle. Next, we look at the attacking characteristic of various types of knee dislocation. Anterior dislocation of knee joint is suffered from violence from anterior to posterior, which directly acts on the lower femur or the upper tibia from posterior to anterior, so that the articular surface of the femoral condyle moves backward along the tibia plateau, breaking through the posterior side of the articular capsule, and the anterior knee dislocation occurs. In the process of dislocation, simultaneous breakage of the anterior and posterior cruciate ligament is most common, and there are also separate breakage of the anterior cruciate ligaments. And most of the tibia and fibular collateral ligament are broken at the same time, often accompanied by popliteal fossa vessel and common peroneal nerve injury. Second, the violence of posterior dislocation of the knee joint acts on the upper tibia from anterior to posterior, causing the tibia plateau to dislocate backward, resulting in posterior dislocation of the knee joint. The kind of dislocation is rare, but the injury is extremely serious. After dislocation, injuries of popliteal fossa vessels and common peroneal nerves are the most common, but also several anterior and posterior cruciate ligament and tibia collateral ligament breakage injury, and tendon rupture or pinna fracture may occur. Third, when medial and lateral dislocation occurs, the knee joint is subject to violence from the lateral side, or indirect violence is transmitted to the knee joint, causing extensive varus or valgus of the knee joint, resulting in breakage of lateral articular capsule and ligament and forming lateral dislocation. Lateral dislocation is more common and medial dislocation is rare. It can be combined with breakage of cruciate ligament and collateral ligament. Medial dislocation may be combined with common peroneal nerve injury. Injury of popliteal fossa vessels is rare. Finally, rotational dislocation often occurs when the knee joint is slightly flexed and the lower leg is fixed, and the femur rotates, forcing the knee joint to bear torsional stress, resulting in rotational dislocation of the knee joint. This rotational dislocation can be divided into 4 types based on the different positions: anterior internal, anterior external, posterior internal, and posterior external. Generally, the displacement amplitude is small, and there are fewer vascular and nerve injuries. It is worth noting that when the knee joint is completely dislocated, it often causes serious tearing and pulling injury on the soft tissues around the joint, resulting in fractures caused by tearing or extrusion of bone attachment to the tendon and ligament, such as tubercle of tibia. Because of the knee joint is superficial, the dislocation may be open. Anterior and posterior dislocation are often accompanied by popliteal artery and vein injury, which will lead to limb necrosis and amputation if not handled in time. So, what are the clinical manifestations after knee dislocation? Besides severe pain, swelling, and dysfunction of knee joint, all of them have special signs of dislocation. For example, for patients with partial dislocation due to the difficulty of interlocking between tibia plateau and femoral condyle, they often perform reduction themselves without deformity after dislocation. For patients with complete dislocation, the knee is obviously deformed. The lower limbs are shortened, lateral movement and elastic fixation can occur. At the dislocation, upper tibia and lower femur can be touched on the anterior, posterior, or lateral side of the knee. Secondly, when the cruciate ligament is broken, the drawer test is positive. The lateral test is positive when the medial and lateral collateral ligament are broken. If the lower leg and toe are pale and cool, or the knee is seriously swollen and cyanotic, there is obvious bleeding or hematoma in the popliteal fossa, and the pulse of dorsalis pedis artery and posterior tibial artery disappears. It means that the popliteal artery may be injured. If the tibialis anterior paralysis occurs after injury, and the skin sensation of the lower leg and the anterolateral side of dorsum pedis weakened or disappear, it means that the common peroneal nerve is injured. Finally, the anterior, posterior, and lateral X-rays of knee joint can identify the type and degree of dislocation, as well as whether there is complicated fracture. Because the knee dislocation is an emergency, once it is diagnosed, manipulative reduction should be performed under sufficient anesthesia. If it is accompanied by vascular injury and does not recover after reduction, surgical exploration should be carried out in time to avoid delaying the timing. If nerve injury occurs and it is tractional, it can be recovered automatically without special treatment. If the ligament, tendon, or articular capsule is incarcerated and hinders manipulative reduction, early surgical reduction should be performed. In terms of medication, it is similar to patella fracture, so we will not repeat it here. Surgical treatment should be considered when closed reduction fails and combined with vascular injury, extensive ligament injury, and articular capsule injury. Clinically, appropriate surgical repair methods should be selected based on the specific conditions of combined injuries, but emphasis should be placed on the restoration of blood supply to the affected limbs and the reconstruction of the stability of the knee joint. After reduction and fixation, attention should be paid to raising the affected limb to facilitate swelling elimination. At the same time, knee flexation and extension should not be done turning. If the knee joint is obviously unstable, the fixation time should be extended to prevent traumatic arthritis. Well, this lesson is over. Please review and sort out the relevant contents. Thank you.